Good morning, everybody, or good evening. I guess it's evening. Welcome to the JVS Online Journal Club. We're going to give everybody a couple minutes to come in. People usually filter in right at the top of the hour, and then Dr. Chang will kick us off and get us started. All right, Dr. Chang, you ready to go?
Yep. All right. I'm going to open back up. All right. Well, thanks for joining us, everybody, to our monthly JVS Journal Club. We have two exciting papers tonight. I'm Kevin Chang. I come from Wake Forest University in North Carolina. I'm just thrilled to still be able to be considered a young surgeon for a couple more years. Our two papers tonight really focused on looking at a novel way of using MRI imaging to define plaque morphology in the tibials and looking at textbook outcomes for lower extremity and PAD bypasses. We'll have presenters from today.
Kevin, are you
Let
sharing
me share.
your screen? Is
Let
it
me
just
share.
me
Yeah.
that can't see it? Is it me?
I thought
Sometimes
I
I'm
was
the
sharing.
problem.
I think
Okay,
it's okay.
perfect. Got it.
There,
You see it
shows
now?
up there. I'll put it in presenter mode too, so it's not so awkward. Doo-doo-doo. All right, is everyone still seeing it okay?
You see it as the presenter view, but
Yep, why don't you just swap the screens? Do you know how to do that?
Let's see.
Under display settings at the top, hit the little caret.
Don't have that quite so well. Let me see if
You
I can
see where it
switch.
says above the presenter mode, it says show taskbar, display settings, and in slideshow.
Oh, I see. These display
Yeah.
settings, swap presenter view and slideshow. Is that
There
right?
you go.
Does that look better?
Well, now, yes, perfect.
Okay, perfect. Pleased to welcome Dr. Kashyap and Dr. Talbot from Corewell Health, which will be talking about the paper on MRI imaging. And we will also luckily have the authors from several of these papers with Dr. Sickles, who's our first author for our textbook outcomes paper here, with potentially some additional authors joining us with Dr. Novak, Dr. Filiberto, and Dr. Beck, potentially to get their opinion and background on what sparked the development of this paper. And our additional authors, Dr. Crichton and Dr. Roy from Houston Methodist, giving their background and their insight into the development of their novel paper on MRI imaging. Again, each one of these papers will have a sponsored moderator and a discussant. Dr. Suko and Dr. Mintz will be our two discussants for these papers. As some of you have already been part of this for several months on end, there's a little bit of variation and change in our updated format, a little more focus on kind of the critical appraisal of these papers and sort of looking behind the curtain for some of these with the authors. It's going to be a new change. But some reminders, please stay muted during this discussion. I'll have the chat open to make sure we can see the comments that come in. We'll try to flag you if you have comments in the chat. I may call on you to ask your question out loud to kind of start the discussion at the end of each paper. This is being recorded and will be uploaded to the YouTube channel for JVS to make sure this is available for post a lifetime review. And just a reminder, our next online journal club will be in about a month or so on May 13th, 6 p.m. Looking at the topic of pediatric vascular trauma and oncologic resections, hosted by MGH and the University of Toronto. Again, same registration channel through Vascular, the SVS website is available. Without further ado, we'll go ahead and get started with our first paper with Dr. Kashyap and Dr. Talbot, looking at clinical MRI imaging defined plaque morphology, predicting guide wire crossing failure in below-the-knee occlusions in a translational model using amputated lower limbs. I'll stop sharing my screen.
Yeah, well, wonderful. Good evening, everybody. I'm Vic Kashup. And really, I want to give a shout out to Doctors Chang, Humphreys, Drudy, and others who've organized this journal club for many years now. Kudos to all that you do. And congrats to is it Crichton, I think, Dr. Crichton and Dr. Roy for a fabulous paper and getting selected. I don't know about the rest of you, but we have a lot of angio conferences where we argue back and forth about whether the patient is an endovascular candidate. Does that still happen in your neck of the woods? It sure does happen in Western Michigan, and we go back and forth, often with a lot of subjective opinion and not a lot of data about whether or not we should try an endo approach. And interestingly, many years ago, I and others, when I was in Cleveland, published a paper about luminography and how luminography really, that is angiography, underestimates the plaque burden in patients. And kudos to, again, Drs. Crichton and Roy for investigating this and really looking at something that we don't understand very well from angiography, which is plaque morphology and whether it has ramifications. I'm going to turn it over to our very talented resident, Ben Talbot, who, Ben, you're an ex-pilot, if I remember correctly, and a talent, Renaissance man of many different talents. So take it over, Ben.
Thanks. Once a pilot, always a pilot, though, is how I like to think of it. So yeah, I just want to say good evening. Thank you all for this kind invitation. Again, my name's Ben Talbot. I'm the third year integrated vascular resident here at Corewell Health Michigan State University here in Western Michigan. We're going to be discussing the paper, Clinical Magnetic Resonance Image Defined Plaque Morphology Predicts Guide Wire Crossing Failure in Below-the-Knee Occlusions in a Translational Model Using Amputated Lower Limbs, with authors as listed below. So essentially, this is a question that's looking at whether the MRI-defined plaque morphology can predict guide wire crossing success in below-the-knee disease. The clinical question is very strong here. Certainly one of the biggest reasons for failure in below-the-knee interventions is simply not being able to cross the lesion. If we had some way of predicting a lesion's crossability, it certainly could give us huge advantage, has huge implications for how we approach endovascular limb salvage. And so I think what the authors are really asking here is whether plaque composition, specifically as defined by this non-contrast MRI, can predict which lesions are crossable. So we have a very clear testable hypothesis, and importantly, it targets a real decision point in practice, whether to attempt endovascular therapy or we need to try some other intervention. So the study design, this is a single center prospective, non-randomized, but the key feature is that it uses an amputated human limb model. And I'll put the inclusion and exclusion criteria there. This study design has some very key strengths and some limitations. On the strength side, it really allows the authors to study real human atherosclerotic disease in a very controlled environment. It really allows them to isolate the plaque characteristics as the study variable. With the disadvantages that while it's still a human limb, this is not a clinical model. There's no actual blood flow, no thrombosis we're dealing with, no vessel reactivity. So really at its core, this is a mechanistic study of crossing difficulty and not at all a study of clinical outcomes. I'm just listing some of the population variables there for us to recall. The population is also very specific. The study has 27 patients with 46 lesions. All of these patients had chronic limb-threatening ischemia undergoing major amputation. And so this really represents the most advanced end-stage disease that we see in practice. So while this is a very relevant group to study from a mechanistic standpoint, it does raise some questions about potential selection bias and limits how generalizable this is to some of the maybe non-severe patients that we are treating. From an outcomes standpoint, the primary endpoint is very straightforward, whether this lesion could be crossed with a wire and a catheter or not. So we have a very clinically meaningful procedural endpoint. It's fairly simplified. It's a binary outcome. We don't really have any graduation of difficulty. There's no time to crossing and minimal escalation strategy. But importantly, there are really no longitudinal outcomes. We're not studying patency. We're not studying limb salvage rates. So this remains a purely mechanistic technical endpoint. Going back, and really the main result here is very striking. We're looking at the hard lesions defined as more than 50% collagen or calcium were non-crossable 91% of the time, compared to just 8% of the soft lesions. And this is an extremely large effect size. I also found it very interesting that the traditional scoring systems like Task-2 had predictive value, but GLASS did not reach statistical significance in its predictive value. And importantly, out of our hard lesions, the minimally calcified hard lesions behaved just as poorly as the heavily calcified lesions, suggesting that a collagen-rich plaque may be an under-recognized contributor to crossing failure. From a statistical standpoint, this is a small study, 46 lesions total using simple statistical tests like Fisher Exact and a Mann-Whitney. But when you see such a large effect size in a small, very highly controlled study, this does raise some questions about is our effect size being amplified by the conditions of the study? There's no multivariable adjustments. We're looking also at multiple lesions from the same limb are being treated as independent observations. So while we have a very strong signal here, the generalizability is a little limited. So the big takeaway here, I think there are two very big key things that this study shows well. The plaque composition appears to very significantly matter for crossing success. And the second that I thought was very interesting, in their hard plaques, it's not just about calcium. These collagen-rich lesions may be equally important and certainly not as well visualized with our conventional imaging. These are very meaningful mechanistic insights that this study brings to light. What this study doesn't do is demonstrate improved outcomes. It does not reflect in vivo conditions, and it doesn't tell us really how to incorporate MRI into our daily practice right here and now. So just putting it all together, we have a very well-designed mechanistic study and a controlled non-physiological model of end-stage disease that shows plaque composition plays a likely major role in crossing success, but does not yet demonstrate how that information is going to change our day-to-day management in our daily patients. And then I think I turn it over to the authors.
Yeah, thank you, Dr. Talbot. I'll take it from here. Hi, everybody. I'm Bjorn Zuko from Dartmouth Health. I've been invited to moderate this portion of our journal club. Thank you for the invitation. I've enjoyed being part of these journal clubs, and I've been looking forward to tonight again. So thank you. As you just saw, Dr. Talbot, thank you for a great synopsis and highlighting some of the key pros and potentially some of the limitations of the study. One of the newer features of these journal clubs is that we're introducing a section now for the authors to give us a little bit of background to how they thought about this project, how they came up with their methodology and design, some of the hurdles they may have faced, and a chance to kind of address some of the points that Dr. Talbot just raised. So maybe for the next 5 to 6 minutes here, I'm going to ask Dr. Crichton and Dr. Roy to weigh in, tell us a little bit about it on your end, and then I'll kind of moderate a couple questions from the audience, and we'll try to wrap this part up in another 15 minutes total. So Dr. Crichton and Dr. Roy, I'll give it to you.
Thank you so much. Thank you so much for that overview. That was brilliant. I think you've really hammered some of the key points of our study. And thank you so much all for the invite as well. It's a real honor to be invited and for this paper to be accepted for the Journal Club today. So talking about the motivation of this study, I think that one of the key things is we really don't know what we're up against, particularly in below the knee arteries. And a particular problem when we're treating these patients is immediate technical failure. So you look at the big trials, BASIL and BEST-CLI, and we're looking at 30 years of data, completely unchanged immediate technical failure rate of 1 in 5, 1 in 6 patients. And I think that this is primarily an imaging problem because we either image from patent to patent, which has already been alluded to by the group, or we have really poor resolution imaging. So what that leaves us with is patients often not even having any cross-sectional imaging before they go into the OR. So we've looked at our patients going into the OR for endovascular procedures, and 30 to 40% of them are not having cross-sectional imaging. And I think actually that's really, we think about doing an EVAR, we wouldn't dream of doing an EVAR without cross-sectional imaging. So why do we do the same? Why do we not maintain that same standard in peripheral artery disease? So I think really the fundamental is that we want to go back to the absolute basics. We really want to understand the pathology of below the knee arterial disease. And we want to try and give people as close to as histological precision as we can with high resolution cross-sectional imaging. And I think that that's what we can get as close to. It's the closest that I've seen that we can get to with UTE MRI. Now, I did see a question pop up about how the UTE MRI works. I'm happy to quickly field that. Essentially, we use currently a knee coil, so it scans in, I think, roughly 20 to 30 centimeter sections. Takes about 6 minutes per scan. It's a non-contrast scan done on a 3 Tesla MRI, and then you serially scan the patient as you go down the leg. So that's kind of fundamentally the kind of basic principle. So if you're looking at scanning a patient from, say, the SFA down, it's probably going to take about 40 minutes of scanning. I know that one of the things that's asked is about this kind of surprising findings, that things that we weren't expecting to come up. So I think one of the things that has been highlighted by Ben is the significant difference in plaque morphology and crossability. So crossability is, again, consistently across the Basel and Best CLI trials, the most common reason for immediate technical failure. That's why it was our focus, and it fits in well to an amputated limb study, which has its limitations of not being, a clinical study without true human arterial flow. So to see such a significant difference between hard plaques and soft plaques was surprising. I think it was really surprising to see how collagen, these hard, non-calcified lesions, behaved so similarly to calcific lesions when it comes to crossability. Dr. Roy's work prior to starting at Houston Methodist was looking at forces required to cross things like collagenous and calcific plaques, and collagen required very high crossing forces. And so to see that then translated into an amputated limb where actually we saw no difference between the two was surprising. And how much of a high proportion these collagenous lesions accounted for. So we've got to remember that these lesions they're invisible to us with our conventional imaging. With a high sensitivity, we can see collagen obviously with things like ultrasound, but to actually be able to consistently identify it with other methods of imaging, we don't have that capability right now unless we use UTE MRI. So I think in this study, it accounted for about 1/3 of the hard lesions that we saw, which I think is much higher than anybody anticipated. We think about challenging disease as being calcific disease. One of the things that was brought up was the fact that glass wasn't statistically significant for differentiating crossable versus non-crossable lesions. I think that that's probably going to end up being a type 2 error. I think as we increase the number of patients in this study, we'll probably see that will become significant, but it's about precision. So does class really give us the ability to understand how challenging a case is going to be? I'm not sure it does. One of the other things that we have been working on is using this model to test out devices. So we presented our work at the VEITH Symposium in the winter, looking at Bayless's radiofrequency power wire. And what we can see is that does have the capability to cross these collagenous lesions. So I don't have any kind of pictures with me today, but that's something that we would probably like to have shared more about that didn't reach the paper. Maybe that's something that we can bring in the future. Other things that didn't get in. So this was about half the patients for this study. So this is an American Heart Association funded study. Just last month, we've completed recruitment. So we now have 50 amputated limbs recruited into this study. We'll therefore probably have double the amount of lesions. So I think that the GLASS scoring will show that it's more significantly associated, going from non-significant to significant. Another thing that we looked at was comparing stenotic versus occlusive disease. So we didn't see any difference of that in this study. That probably will show significance, but I don't think it's going to be anywhere near what we saw between hard and soft lesions. But the real big bit of this study, the huge advantage of using an amputated limb study is the histological outcomes that you can get from this. So every single case then goes on to have the artery harvested. We are then able to corroborate what we see on histology with the MR. So this allows us to validate the imaging technique, and it allows us to assess vessel wall injury. So the early findings that we're seeing is that even with soft lesions, crossing with a catheter and a wire is not benign, but we'll be able to show you the differences in plaque morphology that are MRI identified as to the track of the wire, the level of vessel wall injury, the presence and severity of dissection. And then finally, we are now translating this into an in vivo study. So we have an NIH-funded study that is, we are doing UTE MRI scans on patients going for endovascular procedures. So that is allowing us to translate this into real-life clinical practice. The surgeons are blinded to the MRI, so it's not for planning at the moment. It's to relate the clinical outcomes and the, things like immediate technical failure. But really what I think is going to be very interesting is looking at case planning, looking at device selection, and looking at vessel wall remodeling. So we're also doing follow-up imaging on patients to finally be able to get almost a histological understanding of what is happening on a vessel wall level, depending on what device we have, because we've got a huge plethora of devices. So it's been a fantastic study to be part of. I've been working in the Dr. Roy lab for almost 2 years now, and I look forward to sharing more information in those future studies. But yeah, that's all I've got to say for now. I'm looking forward to questions.
Thanks, Dr. Crichton. Just to highlight, again, you did a great job giving us a background, giving us some insight into what Dr. Roy is championing in terms of research of plaque morphology using MRI and some of the other research. I would point you to the chat. There is a link in there to some of her follow-up in vivo study happening right now, if you'd like to read some of the follow-up work. To go back to Dr. Anil Hingorani's original question here about the cost and the methodology of the MRI, I think in part what he's getting at is what I'm questioning myself, is MRI currently is not part of my paradigm when it comes to PAD treatment. It's duplex-based or CT-based angio evaluation preoperatively. And an MRI is difficult to obtain and still frankly costly and time-consuming. So is there some corollary we can draw to perhaps duplex ultrasonography or even CT angiography that might help us better assess the plaque and plan? You were indicating a third of patients don't get any cross-sectional imaging. Can we get some of this with a quicker, cheaper, faster methodology rather than putting everybody in an MRI?
So
I think
I think,
that,
go on, Dr. Roy,
I was
please.
just going to say, we get this question a lot. And right now, MRI can show us a lot of information that can avoid failed angiograms. And failed angiograms are way more expensive than MR. So we've really changed our practice at Houston Methodist to do, in patients that we are planning an intervention for, we do KISS MRA, a non-contrast MR, which is more sensitive for these runoff vessels. It makes your procedures faster. You can go straight to bypass if you see something that's going to be completely occluded, and you can feel more confident in that. So I think that with those kind of avoided failures and some of these, we actually see, oh, hey, the wound bed is actually being supplied pretty well, and we don't need to do an angiogram for this. The avoidance of these failed angiograms or unnecessary angiograms really make up for the costs. And then, of course, there's additional complications and delays to definitive revascularization. So I think that this is something that we've adopted more and more. That being said, we are looking at how it relates to photon counting CT, so CT scans, and if we can use that information, because I know that can be more accessible in some ways, and we are looking at some of those corollaries.
That's a great answer. And I think championing something that's still novel and will require a little bit of dissemination. So I hope to hear more about it and read about it as we go to some of these meetings. Dr. Vik Kashyap has a question. If you wouldn't mind, please go ahead.
Yeah, thank you. Thank you, Bjorn. Tricia, great paper. 2 quick questions. I know we're running out of time. One, you did both antegrade and retrograde recanalization, and I imagine the operator was you looking at the methods. In my experience, going retrograde, often the distal cap is a little different than the proximal cap, often easier to cross. Any insight there? And two, I think the $64,000 question is, how does this translate to long-term patency? The assumption is that the harder plaque is going to be more likely to restenose or reocclude. Is that been your experience based on the clinical data you have? Thank you.
So the differences between retrograde and antegrade, yeah, we do see some differences where you do have some concavity if you approach it from a retrograde process. For us, these were amputated legs, and so a lot of it was dictated by where the lesion is. So, having enough distance to be able to cross it effectively. But the reason why we did it in an amputated leg is that you can do the histology afterwards, and you can see the vessel wall damage that we're doing with the wires or the devices that we're using under the microscope. Now, with our clinical studies, we have published, a really small pilot one where we did see higher reintervention rates with those that were characterized as being hard with the MRI. So I do think that the plaque complexity, difficulty crossing, things like that do create vessel wall injuries that impact your restenosis rates. But we are prospectively validating that in 100 patients in this NIH study.
Thanks for that answer. And I'm going to blend a little bit of what Dr. Kashyap asked with what Dr. Chang had asked in the chat. And that again pertains to the crossability in this amputation model. It is one person using a single catheter and wire platform. It is not accounting for the up and over axis. And yes, you're using a longer running room. So crossing a popliteal lesion predominantly retrograde versus antegrade. Can you comment a little bit more on some of the other techniques out there and the in vivo approaches and how those might have altered your ultimate results in real life?
Yeah, I think in our in vivo study, we certainly see a big difference, right? Like here, we had a very high no crossing rate because these are amputated limbs, and the worst of the worst. In our clinical study, we've done now 43 patients, and we have a crossing failure rate of about 15%. So that's much more in line with the published literature, and it's many more operators. Most of the times, if you're not successful with your first antegrade attempt, still our process is kind of doing it antegrade first, retrograde if you're not successful with that, and then wire and devices escalation. We don't typically use reentry devices as much. It's typically just getting through access.
Thank you. One other question I had in reading this pertains to something you just mentioned about the cap. Your study talks about plaque morphology, but we do have some good data about the cap morphology, the fibrous cap on either end of the lesion for the totally occlusive lesions, convexity versus concavity on either end. Ideally, you are concave at the entry side and convex on the exit side to make sure you remain centroluminally and don't get subintimally. Is that something you were able to assess on your histologic assessment and have any insight on whether MR versus a duplex pre-op might give us a better sense of cap morphology?
I think that the cap morphology is a little bit more relevant when we talk about like SFA flush occlusions. When it comes to the tibial or below the knee vessels, we see a lot more heterogeneity along the length of the vessel. So you don't have as much of those defined caps as you do see in the more proximal vessels. And so, yeah, I do think that if you can see a defined, concavity, that can help assist your crossing success, and that is something you can probably see on ultrasound as well. But in these really calcified tibial vessels, ultrasound can be tough too.
I think what we'll see as well is that the histology will show us that we're subintimal a lot more than we think in the below the knee arteries. And I'm going to be really interested to be able to share in the future how often we're causing quite significant injury to the artery just with a wire and a catheter.
Great. Well, thank you for bringing your paper to us tonight and letting us discuss it and ask you questions directly. It's always a rare honor and a privilege. Grateful for the questions of everybody, and at this point recommend we conclude the first half on this paper and move on to the second one. So thank you.
Well, as we are exploring, as I mentioned, or as Dr. Chang mentioned in the beginning of the meeting, we are exploring new pathways and new ways for us to do Journal Club, as well as expanding it to various other groups throughout the country and actually throughout the world. We will be changing the times intermittently a few times a year so that we can have colleagues from other countries join. It's just something to keep in mind or know. And as some people may think it's a treat, some people may think it's punishment, but for tonight, I am going to present the second paper, and we're going to take a little bit of a different twist in terms of how we've done Journal Club in the past. So I have the luxury of presenting the next paper about textbook outcomes from Dr. Sickles and the group at UMass UAB. And I'm going to sort of introduce the concept of textbook outcomes before I bring up the paper. Textbook outcomes are something that have gained a lot of traction all throughout the surgical research, specifically in areas such as surgical oncology, general surgery, cardiothoracic surgery, transplant medicine. And really what you're looking at is this composite outcome of a variety of different metrics. So for instance, let's take something as simple as maybe a peripheral bypass or aortic surgery. You're really talking about the textbook outcome of 30-day survival, major cardiac events, renal failure, reintervention, and you're putting all of that into this sort of classification of a textbook outcome. And it's not something that has been traditionally looked at in vascular surgery. And so I do think we'll start to see a little bit more and more of this as we go forward. So I am going to share my screen and I am going to bring up the next paper that we'll be discussing, which is on, I'm old and it's very complicated on how to get things to start. There we go. Textbook outcomes for lower extremity bypass. And as I mentioned, just in terms of the background, we're really seeing a lot of this composite quality metrics capturing what perhaps the ideal perioperative result looks like. And it's been validated in a few other areas. The authors have presented on or published on this before too, but it hasn't really been explored in this lower extremity cohort. In terms of the study design, this is a VQI study and for all elective lower extremity bypass cases, and they divided them into 3 different cohorts. That'll be kind of displayed with the numbers of each on the next slide, but you're looking at suprainguinal anatomic, suprainguinal extra anatomic, which includes obturator bypasses, axillofemoral bypasses, fem-fem, and then infrainguinal bypasses. And the study windows differed a little bit just because of the data set for suprainguinal database and when it started. The way that textbook outcome was defined is that it required meeting all 5 of these criteria simultaneously. So no major complication, can see some of those listed here, no major medical or no surgical complications, no medical complications, no adverse limb events, no prolonged length of stay, and then discharge. So where they went after discharge. And the length of stay threshold is really something that I think for most of us is a big problem. I know for our group it is, but the threshold was 75%. And let's see, next slide. There we go. So when we look at the study cohort, the suprainguinal bypass, we're talking about 7,200 patients, or suprainguinal extra anatomic, and the infrainguinal numbers, of course, we do a lot of those. I think everybody in here can see the huge number over there. The exclusion criteria were pseudoaneurysm, infection, procedure-based sort of isolated endarterectomy, thrombectomy. And then when you look at the non-textbook outcome to textbook outcome profile, which you can see in table 1 for those of you that do have the paper, you know, the non-textbook outcome group was really older females with an extreme BMI, non-white race, ambulatory dysfunction, a lot of the things that we know make patients at a lot more risk. And so they analyzed all 50,000 of these patients, and this is what the textbook outcome rate was. So the achievement rates ranged from 60 to 67%. So for for suprainguinal anatomic bypass and infrainguinal bypass, it really was almost identical, about 60.7, 61%. Extra anatomic bypass had the highest rate of textbook outcomes at 66.9%. And then it seems a little, in my mind, it seemed like that was a little counterintuitive, because if you go through the paper, you could also see that those are some of the patients that had the heaviest comorbidity burden. The key point, I think, here, when you're looking at these, is that 40% of patients do not meet all 5 criteria for a textbook outcome. And the most common reason for that, which I'll show in just a minute, is because of length of stay, prolonged length of stay. And I think that's important because it's possible that length of stay is something that can be changed. Early mobilization, coordinated discharge planning, maybe from the start, proactive therapy, those are all ways that we can potentially look at how length of stay could be moved. This slide here is the 1-year survival. Achieving textbook outcomes really was the strongest independent predictor of 1-year survival across all 3 of the groups. And you can see the hazard ratios here for suprainguinal anatomic, extra anatomic, and infrainguinal bypass. But when you met the 5 criteria for a textbook outcome, you had improved 1-year survival. And I think in some ways that's some of what we know, because we do know that patients who are healthier with lower comorbidities, who are ambulatory, have better outcomes. And so it's just displayed here, but using this composite endpoint. And so one thing to keep in mind is that the authors also ran a sensitivity analysis looking at removing 30-day mortality when they looked at the textbook outcome. And that way they took away this kind of confounder of in-hospital death when you're looking at these 1-year metrics. When we think about the risk factors for failure to achieve textbook outcomes, which you can see here in these forest plots, again, broken down by the different groups, the multivariable analysis really shows that there's a consistent pattern across all these procedure types in terms of the more comorbidities, the less likely to have these textbook outcomes, specifically with anemia, increased blood loss, tissue loss as the operative indication, non-white race, impaired ambulatory status, and then comorbidities such as COPD and CHF also kind of appear very consistently here. And several of these could be actionable. So patients with anemia, can you get them worked up? Can you get them healthier? Can you look at your blood loss in terms of how you're doing your surgery and meticulous technique? And then I think there are also 2 findings within the infrainguinal group that deserve a comment as well, which is infrapopliteal bypasses had a higher risk of non-textbook outcomes, which reflects potentially the more demanding reconstructions and the worse underlying disease. Unlike the extra anatomic bypasses, the next thing is looking at volume. So extra anatomic bypasses, high volume centers, getting your surgery there was protective. But for infrainguinal bypasses, if you had your surgery done at a high volume center, it actually was more associated with a non-textbook outcome. And I think that's an interesting thing for us to kind of talk about too, as we move into the author's discussion of this paper, because are we choosing the patients correctly? And I think we all go out on a limb sometimes doing these cases in patients who we know may not have the best outcomes, but we get pushed into that because of the severity of the disease. They also looked at center level variation. And so the funnel plots over here identified these outliers. So for suprainguinal anatomic bypass, there were 4 or 5 outliers, 1 above and 4 below the observed versus expected ratios, and then extra anatomic and infrainguinal. And on the pictures on the right are a comparison. They're sort of a bar graph comparison rate for textbook outcomes for one selected underperforming center in for suprainguinal extra anatomic bypass, and A looks at the one selected outlier performing infrainguinal bypass, or sorry, B looks at infrainguinal bypass. So A is extra anatomic bypass and B is infrainguinal bypass. And if you are a center that has perhaps worse outcomes, so if you look at the extra anatomic bypass group, which is the top graph, there was a 34% rate of textbook outcomes versus the national average of 67% or 66.9%. And only 42% of the patients there met the non-prolonged length of stay compared to 77% of patients nationally. I think if you're looking at this, if you're one of these centers and you're looking at your data, this is another data point for you to look at what kind of quality you are doing as an institution. So that's one area. I also think there's another critical point here too, which is 30-day mortality was 97% versus 91% nationally. And while that's it's not particularly statistically significant, it's possible that looking at textbook outcomes altogether, you would miss this. You wouldn't see that the differences here in those particular mortality rates whenever you're looking at just mortality, but when you put textbook outcome together, you see that that's actually a difference between these two centers. And I think that's really the kind of the core argument of the paper itself. So in terms of verdict, what the study does tell us is that textbook outcome rate can achieve centers can achieve textbook outcome rates of around 60 to 67%. So there is this significant room for improvement. Roughly 40% do not have the ideal perioperative outcome. And when you do not have a textbook outcome, you have a lower 1-year survival. And I think that's, again, the most clinically important finding. There are modifiable risk factors: anemia, estimated blood loss in the OR, ambulatory function. All of these things are things that we can look at and help make decisions about patient selection, implementation of prehab or targeted optimization clinics. But the study can't necessarily tell us whether interventions to improve textbook outcome rates will actually improve survival. There's really an association here. It's hard to know what the causation is. And then long-term outcomes, vascular surgery durability, we're talking 3 to 5 year outcomes sometimes. And so lower extremity bypass really needs to be looked at in terms of the 3 to 5 year data. And then finally, the centered information. Textbook outcomes doesn't include things such as quality of life, function, wound healing, or some of the patient's own priorities whenever they come and undergo surgical treatment. So I will stop sharing my screen and we will turn it over to our author group, or actually I'll let Dr. Mintz to moderate and go forward.
All right. Thank you, Dr. Humphreys, for that wonderful presentation. And yeah, as noted, we are lucky that we have several authors from the paper here today. So we are going to toss it over to them to really talk to us a little bit about why they chose textbook outcomes. Why were they interested in it? How did they go about it? What kind of things surprised them? What was interesting to them? And maybe a little bit more about where they would like to take this. And then in about 10 minutes, a little less, we will take questions from the audience.
Wonderful. Thank you so much, Dr. Humphreys, for that really excellent presentation and a more beautiful display of the data than I have ever made. I've prepared a couple of slides, just kind of talking about our motivations and things like that from the study. Can you all see the screen? Yeah. So we sort of discussed that things like 30-day mortality, especially for an elective procedure that has a pretty low event rate, for a data point like that, it's really difficult to discriminate quality between centers because the event rate is so low. And so overall, traditionally tracked individual outcome measures don't necessarily capture clinical quality. And so we wanted to sort of say, how do we capture surgical quality for patients undergoing elective lower extremity bypass? And so we wanted something that is measurable and perioperative outcome that incorporates both priorities of surgeons and patients. And with the composite, the idea is that you have a higher event rate and therefore you're able to detect greater variability. So Dr. Humphreys presented the concept of textbook outcomes very well. It's emerged across several different sort of surgical specialties, and overall concepts are pretty consistent among the definition of textbook outcomes. Essentially, no major surgical or medical complications, no prolonged length of stay, no perioperative mortality, discharge to home or previous residence, and then really what we included as specific to lower extremity bypass was the freedom from a major adverse limb event. And that's been done in, for example, the surgical oncology space as well when they talk about getting an R0 resection, for example, that's added into their definition of textbook outcomes. So it is modifiable based on the procedure. And so as I discussed, we incorporated the main themes that are present across textbook outcomes, generally speaking, and then as well as no major adverse limb events. The volume outcome relationship, is sort of already discussed, was certainly a surprising finding. It wasn't significant for superinguinal bypasses. But for extra anatomic bypass, it actually favored a textbook outcome. And then for infrainguinal bypass, higher volume centers actually had that was a risk factor for failure to achieve a textbook outcome. And in thinking about that, I think that probably has a lot to do with referral patterns. And I think about our practice patterns here and what's done here versus the community, and a lot of times, especially at big tertiary academic centers, you are getting patients who a lot of other people have already said no to for sort of the risk factors and the reasons that we've already discussed. But I think that overall, generally speaking, we do sort of tend to optimize them as best we can and try to give them a shot in an attempt for a limb salvage. The textbook outcome rate, as we also discussed, was higher for extra anatomic bypass, which is sort of a surprising finding, as opposed to you'd maybe expect it to be higher for anatomic bypass. But again, I think that that's sort of part of the limitation of the study with selection bias of these patients weren't necessarily a candidate to get something anatomic, likely was thought critically about to get an extra anatomic bypass, and did relatively well with that. And then when we looked at the individual center data analysis, high performing centers tended to perform highly actually across multiple of the single variables that's part of the textbook outcome definition. And the same was true for low performing centers. And so I think that the insight there is also that a lot of these centers probably have systems in place and processes in place that help them to achieve that. And I think that looking at those outlier centers more closely and having them sort of be able to say, hey, this is what we do well to be able to achieve this higher textbook outcome rate, and then seeing if that can be replicated at other centers in the future. And I think that's a key kind of future direction for how this can be used and leveraged for individual center data within the VQI. Some things that didn't make it in the manuscript. The framework for the methods of this was sort of already predetermined somewhat from the previous work that the group had done with prior textbook outcomes analysis. We had written a paper on endovascular aortic repair as well as open, and so it was interesting to be able to apply those same concepts to lower extremity bypass. I think something that we went back and forth about quite a bit was the anatomic distinctions and whether we incorporate all lower extremity bypass into one analysis and then have those anatomic distinctions as risk factors versus doing separate analyses, and ultimately decided on doing the separate analyses because of just how different the operations are and the risk of each operation and the kind of patient who's undergoing each operation. We didn't really want to be comparing apples to oranges as much as we could. But as Dr. Humphreys brought up, even within those individual subgroups, there are also anatomic variations that can make patients high risk for achieving a textbook outcome or not achieving a textbook outcome. So I think there is some additional granularity there that we could have broke out several sub-analyses as well. But ultimately made this decision such that we could have these three distinct subgroups that were relatively undergoing a similarly risk profile operation. And then I think something that just I became more aware of as I did this data analysis was there's a lot that the VQI offers in terms of variables characterizing patients' demographics as well as anatomy. There's also a lot that is missing and is not captured. And so I think that we have surrogates for sort of being able to tell how healthy or how sick a patient is before they come into surgery, but ultimately there's so much more data and so much more to each individual patient's profile that can affect how they do postoperatively that's not necessarily captured in the VQI. So some of where this work is going next, I'm going to introduce the concept of earned textbook outcomes for a moment, because I think one of the criticisms of it is that you have all of these individual measures. However, the severity of dying postoperatively is certainly not the same as if you stay an extra day in the hospital. And then also, as Dr. Humphreys mentioned in her presentation, really trying to get more of a qualitative component into this in terms of patient quality of life, return to their prior function, and doing that through a qualitative component as well, I think is a really interesting future direction for this work. So I'm going to show a couple of slides that are illustrating this earned textbook outcomes concept real quick. This is all unpublished so far, but just sort of my thoughts about where to take this next. So essentially what this does is it applies a weight to each probability of the severity of the complication experience. So if the patient achieves a textbook outcome, the weight is applied to the probability of death at a year for all patients who achieve a textbook outcome. And if the patient doesn't achieve a textbook outcome, then the complication-specific weight is calculated based on the patients who do experience that complication. And then so it essentially gets plugged into an equation as shown above. And this was developed in collaboration with Dr. Jones at UMass, who has written a little bit about this methodology as well. So this is one specific complication that we looked at in open aneurysm repair. And essentially what this graph is showing is that if you just take the quartiles of groups for risk-adjusted textbook outcomes versus the centers, when we did this weighted textbook outcomes analysis, you sort of see that there's better discriminatory ability among the four categories of centers than if you just risk adjust it. And then how does this impact long-term survival? So if we just looked at textbook outcomes without adjusting anything, there's pretty good discrimination between the first quartile and the remaining. However, the quartiles 2, 3, 4 remaining, that survival is long-term is grouped essentially, that there's really not much difference. When we risk adjust it, you see a little more distinction between the first and the fourth quartiles. When you adjust it further, looking at outcomes expected above or below average, it distinguishes really the fourth quartile and then less so the first three. But when we sort of bring all of this together, there's a little bit more discrimination between quartiles 1, 2, 3, and 4. And so that's kind of just a quick overview of that, and the methodology is a little bit complicated, so I apologize. I'm a little bit short on time, but we'll turn it back over to y'all and talk more about the paper. But thank you.
Thank you so much, Dr. Sickles. That was really thorough. We really appreciate that and the sneak peek to the extra data. I'm actually going to I see that Adam Beck is on the call, and Dr. Beck and I are both going to hop onto a VQI Governing Council meeting in about 5 or 6 minutes. So I was curious, and I, lob it to Dr. Sickles and the rest of your team as well. So, Dr. Beck, are we adding TOs to the VQI? And is this being used at your center? And what is the actual real life implications of using something like this in your regular practice?
Um, question, and thank you guys for practice. And I would just echo what said, Misty, that was an incredible presentation. You should record that and use it as a how-to for doing a review. That was phenomenal. The whole that came about from I was a program for the Southern Surgical, and there were a whole bunch of papers about textbook outcome in various other specialties, and I started looking into it. There's one paper in the literature from Europe about vascular surgery, and I thought, gosh, this would be a really great idea for the VQI to use as a return on investment for people. And so Angela was doing her dedicated research time, and I asked her to start working on it. She did just a beautiful job putting all this stuff together. And so that's my ultimate goal, is to convince Shravan and Jim that this is a good measurable to provide back to the centers. And
Connection difficulties. But I will, as noted,
can you hear me
it's
now?
something we could do. Oh, yep, you're back.
I'm so sorry. So I was hoping that we would get the earned textbook outcome stuff done, and then we might do both as part of that report. And I'm gonna and so I'll follow up with those folks and see if it's something that we might be able to do in our reports. And I saw that the Loma Linda folks asked that question too, so obviously there's some interest in it.
We did have a question from Chantel Sosa, one of the medical students on the call. I didn't know if you wanted to ask it.
Sure. I'm one of the fourth years at Dartmouth. I was just curious that given the textbook outcomes is a composite metric and has high predictive value for 1 year survival rate, how do you see that fitting into perioperative kind of risk stratification in terms of planning for the specific patient versus to this question of using it for VQI data, institutional decision-making, and possibly quality improvement?
Yeah, thank you for your question. I think it's a great tool to be able to counsel your patients preoperatively on. I don't know that it identified any characteristics or factors that were surprising or that we didn't know beforehand in terms of preoperative risk stratification. But I do think that it is something that you can use to talk with your patients about what to expect afterwards and how it might tie into their how they do in the long term. I certainly think that there's more to be done with textbook outcomes and even longer term survival beyond the 1 year time point that we looked at for survival. The reason that was chosen is that just is typically what is the what we can get reliably from VQI data. And so the VQI is great in the sense that there are a lot of data points and a lot of patients. However, its utility for things like long-term data is a little bit more challenging because for so many patients, the follow-up just isn't there. And then for center level quality improvement initiatives, I think centers. I displayed two of the graphs for specific centers that were outliers, both an overperformer and an underperformer. And I think individual centers can do just that with their data for individual variables within the textbook outcome. And I think it can really help isolate areas where future quality improvement efforts can be directed to help them achieve a greater textbook outcome rate overall.
Do you see am I going to sit down and read a whole list of what textbook outcomes are to my patient and be like, here are the things that you may be at higher risk for if we do this surgery? Like how just real world on the ground, how do you plan to phrase that when you talk to your patients?
Yeah, I think unless they're particularly interested in clinical quality improvement research, it won't be too much of an interesting discussion for them. But I think that the things people care about and the things we looked at for the long-term variables, mortality, freedom from bypass occlusion, and the likelihood that you're going to keep your leg, I think are big things that both we care about as surgeons and what patients care about as well. I think it's also, to kind of tease a little bit more of this out, going to be important to do a qualitative aspect as well, and talk to patients about quality of life and restoration of function and things like that, to see if that's not something that we can incorporate into this as well, and that can help us counsel patients in the future.
I think this really adds to the call to add patient-reported outcomes to our data sets and find ways to actually do it so that people across the country can find that data, get that data to their patients, and do that within their clinical workflow, right? Like we need to find out what's important to them, and we need to figure out a way for them to be able to report it so that we can have that as part of the data set. All right, we did it. We're on time, Misty.
Well, thanks everybody for being here and for participating. As was mentioned in the introduction by Dr. Chang, in May we will be doing a pediatric focused JVS Online Journal Club. Will be talking about oncologic reconstructions in pediatrics, and we'll have special guests that are focused in pediatrics and vascular surgery to help provide guidance. So thank you all. See you all on May 13th, and have a great night.